Okay, so we'll get started. If you possibly can you like get a thing in just so we have like the attendance side of this. So we're continuing. We're going to finish off the our discussion about pain and pain mechanisms, and so we have a question from Wednesday's class. If a patient with diabetic neuropathy has a small cut to the skin, which of the following responses will be seen? And so this is a question about that triple response. And so the triple response is, you know, like the sort of little thin red line, then the flare, and then the wheel in the center of that. And so two of these, A and C, are driven by mast cells. And those mast cells are actually stimulated by little axon branches, which have responded to the injury to the skin, and then those mast cells are being stimulated. And then the flare is due to stimulation of the blood vessels, also through this sensory nerve. So all three of these are driven by the sensory neurons. And so in some patients, so it's not seen in all patients with diabetes for sure. And it's not, you know, like it can be sort of not cut and dried even in patients with diabetic neuropathy, but in at least some of these patients, they will lose all of those responses to sort of the small skin injury. Whereas in someone with a fully functioning peripheral nervous system, you'll see A, B, and C as all of your responses. So this is a kind of question that's more of a kind of way of, you know, just kind of reinforcing, you know, like that element about the triple response and the way in which these sensory neurons in the skin actually do have all of these other just direct connections that don't really involve the rest of the nervous system at all. This is just sort of like the axon branches, which are acting both to detect the injury and then to stimulate just local responses. So our next subject for finishing off the discussion about pain is pain circuits. And so we talked about the sort of straightforward reflexes with, you know, like where it's sort of like the muscle stretch reflex with the sort of little hammer and so on. The pain circuit reflex is very, very similar to that. It's, you have some kind of stimulus, which is stimulating fast fibers, which will then lead directly to the spinal cord. You'll then be activating certain muscles. You'll be inhibiting other muscles in order to get a very rapid withdrawal reflex, in order to sort of obviously try and minimize any kind of danger. So this is all occurring at the level of the spinal cord. There's no sort of requirement for any sort of fancy thinking within the brain in order to get that kind of withdrawal reflex. This is, of course, why when you put your finger on a into an open flame or something like that, you can pull it out pretty fast. However, that doesn't mean that sort of more complicated things don't happen with our perceptions of pain. And that goes sort of all the way up to sort of, you know, like mid-levels of the brain itself. And a lot of this is driven through these descending modulatory pathways. So the spinal cord, you know, like we haven't really been able to sort of go in depth into all of the circuitry that's present within the spinal cord, but it is actually a pretty complex neural system in its own right. And is sort of, there is some level of pain processing that occurs within the spinal cord, like within the segmental portions of the spinal cord. But for simplicity, we're sort of kind of gliding over that. And instead we're talking about these, especially these descending pathways. And so these come down from the periaqueductal gray in the midbrain. And there are two main descending pathways, a serotonergic pathway and a adrenergic pathway using norepinephrine as its neurotransmitter. And both of these pathways are able to essentially interact with the sort of segmental pain processing pathways within the spinal cord in order to sort of minimize pain transmission. So these are sort of, can be considered as sort of the sort of inhibitory pathways that are suppressing the detection of pain. And these, of course, are involved in medications that sort of, like certain types of medications that are involved in analgesia. The way in which they get enlisted is through obviously higher centers. And so I've kind of circled the, key ones to sort of, there's like a lot more to it than this, obviously. But so obviously the somatosensory cortex is going to be where you become like consciously aware of pain and where you consciously localize that pain. Because like this is exactly the same as touch. The somatosensory cortex has this somatotopic map, which basically, so as you kind of move down the brain, you can sort of, each bit is sort of focused to a particular region of your body. And so those bits will light up with either, touch sensations or with pain sensations, allowing you consciously to be aware of, like, oh, I just stubbed my toe or something like that. Obviously, the thalamus is also involved because that has those direct projections, as we talked about, that kind of line up particular sensory areas to their corresponding cortical areas. The periaqueductal gray we have just talked about because that's that pain-specific kind of relay station. It's from there that we have those pathways that are going down to sort of try and suppress excessive pain. And because pain is very strongly associated with especially sort of fearful and emotional responses, the amygdala is also highly tied into our sort of central processing of pain. And there's obviously a lot more that goes into sort of our perceptions of pain and so on. And some of that is actually kind of interesting and is an area of current clinical research, which is that it turns out that you can consciously adapt your pain responses, like to quite a significant extent. So, for example, if you have a patient who is, like experiencing a painful stimulus, or in this, like, so these are studies done with volunteers rather than patients, but they're sort of experiencing a painful stimulus. And then if they focused on, say, a photo of like, a loved one, then that painful stimulus will diminish in its intensity. Similarly, if you sort of meditate while being exposed to a painful stimulus, that can also sort of suppress the sort of, like painful stimuli. And there was the study of patients with fibromyalgia where there's like significant continuous sort of pain, and they were given something called cognitive behavioral therapy, which is a way of like trying to sort of metacognition is kind of the idea where you're trying to sort of train your mind to sort of think in particular ways, and they can also significantly reduce their pain score through essentially mental activity. And all of this basically means not that there's sort of no need for sort of analgesics, but that some kind of psychological approach can actually be quite like effective in conjunction with analgesia in order to sort of control pain. However, not all of the circuits in the brain are geared towards suppressing pain. And so you also have a situation where there's central sensitization, which is basically the circuits within the CNS are actually making the pain worse. So you'll remember things like the triple response are all about peripheral sensitization. So they're, like all of those, like things like the release of the histamines and so on is actually making the site of the injury more sensitive to pain. Central sensitization is not occurring at the site of the injury at all. It's all in the spinal cord or the brain itself. But it leads to this exaggerated response to a normal stimulus. And it also creates enlargement of the receptive fields because it starts sort of lumping different individual sensory neurons. It lumps their inputs all together so that like you might have started off with sort of like a tiny sore point in the point of your finger, but central sensitization will lead to sort of bigger and bigger receptive fields. So eventually you could end up with sort of your entire hand hurting just because of this phenomenon. And one of the aspects of that is that there's sort of this reduction in effective activation threshold. And so what that can mean, for example, is that a stimulus that would normally be just a touch stimulus is now becomes painful. This is one of the sort of main sort of receptors that's involved in this is this NMDA receptor that's so strongly involved in different types of synaptic plasticity. And in response to this enhanced actions of the NMDA receptor and the synaptic plasticity within the spinal cord, we get release of lots of pro-inflammatory mediators. And for example, prostaglandins are a major one, and prostaglandins are obviously a major target of different types of analgesic medications. So in order to counter this kind of sensitization, we're using antagonists of things like prostaglandins. But because we have those central descending modulators, we could also enhance their activity. And the way in which we can do these is through opioids, which have a lot of activity in the spinal cord and the periaqueductal gray. And you can also, there are alpha-2 agonists that actually do have activity in reducing certain types of chronic pain. In terms of patients' sort of presentations, there's these couple of major conditions. One of them is just wind-up, which is just an acute response to repeated activation of pain receptors. So as you're continually stimulating the same sort of pain receptors, it becomes more and more painful. And so that's wind-up, and leads to that thing where if you keep stabbing the same area on your fingertip, after sort of like 20 or 30 times, it starts becoming extremely painful. Whereas before it was obviously, just a pinprick. Yes.
After like somebody slapped me on the face for many times, it would now instead of like feeling more pain.
Yes. So it does depend on the particular type of sensation. It's usually if it's a moderate sensation repeated, it winds up. So there are different types of experienced pain which can have different types of responses in that way. If you think of the sort of classic Chinese water torture, where it's like literally a drop of water falling on your head, after thousands of repetitions, that is supposedly agonizingly painful. So but it's starting from mild stimuli and then they're winding up. If you're starting from very high stimuli already, then there is stronger activation of the sort of inhibitory pathways, which is why even if you have like a broken bone, which is like really uncomfortable if someone is trying to sort of move it around, it actually after a short while the pain actually goes down a little bit. And so so the wind-up is an acute phenomenon, where you have something like allodynia, which is this change in activation threshold for the sensory neurons. Then it's sort of you have this conversion from touch to a painful experience, and this is what sort of a characteristic of certain types of chronic pain condition, and is thought to be because there is this convergence that occurs within the spinal cord. And so some of these tactile mechanoreceptors, so the ones that are supposed to be just encoding, like non-painful touch, they make some of the same connections to pathways within the spinal cord. And because those pathways have been cranked up by, this chronic pain condition, this is now what's responsible for converting this sort of like just gentle touch into something that's actually, like painful. And obviously this is a significant quality of life issue for those people with these chronic pain conditions. And it's especially a problem with neuropathic pain where, like you can't, there's no possibility of like the tissue healing and then eliminating the painful stimulus because it's not really, it's neurogenic in its origin. It's not because, like you have a burn or something. And then obviously the most extreme version of this, with a nice Scooby-Doo picture, is phantom pain. So phantom pain is obviously pain that comes from a missing body part. So like if you have someone who has their hand amputated for some reason, then like in many cases that hand will, or in the majority of cases, there will be some kind of phantom sensation in that amputated body part. In some cases, it's actually really painful. And like there's not a lot you can do for a hand that isn't there anymore. It's not sort of like, it's impossible, like it doesn't exist. So there's nothing you can directly target to that. And so it's sort of a strange phenomenon, and there's sort of limited ability to deal with it. It seems to be clear that it originates, this phantom pain originates actually in the spinal cord itself. Obviously, again, it doesn't originate in the missing part because it's not there. There's some evidence actually, if you have to have an amputation, that it's actually worth doing, like a spinal block, in addition to sort of the actual anesthesia, in order to sort of try and minimize the occurrence of this. As I say, the mildest form is just like, like the feeling of a sensation in there. And then it sort of has a continuum all the way to sort of feeling this, there's a cramp all the way to actual pain, yes. That's actually a good question. I don't really know the answer to that. I guess the sort of clinical studies don't really like talk about that. In terms of, because it's not just hands or fingers or whatever. So and if you're sort of talking about like a foot, then you don't have very precise localization anyway. So I don't actually know the answer. I think it's interesting. Typically, phantom pain will build up in following the first few days following the amputation, and is typically at the portion of the amputated limb furthest away from the actual site of the amputation. And it can be obviously anything from just a phantom sensation all the way to sort of shooting, stabbing, throbbing, or burning type pains. It's thought at least part of this is down to sort of sensory remapping. And it does have some, there does seem to be some ability to treat it using certain types of antidepressants and anticonvulsant drugs, which seem to help, probably by modifying the excitability of neurons within the spinal cord. And there are some interesting non-pharmacological approaches to treating it. The one I think is the most interesting is this sort of mirror box type approach, which is where, for example, if you have a missing hand, there's a, so if I have a missing hand, we'll put it into a box. And so there's a mirror that basically creates a mirror image of that. And because you have the mirror image, then the body starts to, or the mind starts to sort of think of that mirror image as being the missing hand. And that can then allow a more sort of, like a better awareness that, okay, there's nothing wrong with the hand, it's there, it's happy, as happy as a hand can be. And that sort of helps to sort of reestablish this kind of proper connection. There's actually, just as a total aside, there's a really interesting experiment called a rubber hand experiment. Okay, where if you have a fake hand put on the desk, after a while, you will develop a sort of real connection to this fake hand, and so you can actually start generating fear responses if you threaten that fake hand. And interestingly, you also start to develop an immune response against your own hand that's hidden underneath the desk, which is, like, interesting. You're actually starting to reject the real hand in favor of the sort of fake rubber hand. But so that we will, because we're still running behind, we'll hopefully, like that we've covered and talked about some of this. This slide is there for you to read. It will not have any questions on it, which I know probably means you'll never read it. However, the idea is that sort of this is pain treatments, and so specifically pharmacological ones. So the idea is that you can read it, and they'll sort of just be tiny little seeds of thought that can then be sort of grow into beautiful trees full of knowledge about the pharmacology as we progress through all of this. So now we are going to move to headaches. And we have to obviously try and get through to all of the remaining today's. So the exam next Friday, which is appropriate when we're talking about headaches and migraines, is going to be on. I'm not sure how many of Dr. Lindblad's classes, but it's going to be my first 10 classes, which will basically be including Tuesday's class. But yes. Yes, I have a feeling it's like 3 or 4, but I'm not really sure. Someone said 3, so. So as long as that makes sense. So I think it's going to be I think it's epilepsy is Tuesday's class. So there'll be lots of synaptic transmission and inhibition, which I know everyone loves. So headaches. We have primary and secondary headaches. A primary headache is what you'd expect, that it's like, like when you receive medical treatment, like the headache is the disorder itself. It's, like there's no clear underlying cause. A secondary headache is where it's secondary to something else. Like being slapped in the head multiple times, for example. And then the cure is move away from the person who keeps slapping you in the head. So for primary headaches, the most common type is a tension headache, followed by migraines. And then there's idiopathic sort of stabbing headaches where basically they're not really explained. Then there's exertion headaches and cluster headaches. Secondary headaches are often down to, for example, some kind of systemic infection, then head injuries, vascular disorders, and then rarely things like, although obviously very seriously, things like subarachnoid hemorrhages and brain tumors. So anyone who's presenting with a headache, you need to sort of figure out whether or not it's like a headache or it's something else, because your approach to treating it is going to be obviously very different depending on, like what the cause is. And the interesting thing about the headache is that, or headaches, is that your brain itself cannot feel pain. It experiences the pain of every other part of the body, but it itself does not feel pain. So when you have a headache, basically you're feeling something other than your like nerve cells. So there are extracranial portions of the head that are capable of giving you a headache. So scalp, typically you'd be able to tell it was a sort of a scalp ache, but obviously there's a bunch of joints within the skull which can feel pain. There's the and then you have all of the sort of muscles and so on, which are particularly important in tension headaches. And then things like the teeth, the eyes, the ears are all capable of feeling pain. And again, are sort of very firmly embedded in our head and can give us sort of, have certain types of earache even can sort of almost feel like they're actually headaches rather than just clearly defined earaches. But within the brain itself, the only things that can actually sort of give rise to a pain signal, a nociceptive signal, are going to be the blood vessels, the meninges, and the sort of nerves, by which I'm meaning the sort of, things like the cranial nerves. So all of the sort of, like neurons in your hippocampus, say, you could sort of smack them with a hammer and they'd be turned to mush, but you wouldn't feel anything. And this is obviously significant in brain surgery, for example, because this is why, you can have brain surgery whilst the patient is awake. Because and much brain surgery is whilst the patient is awake, simply because they can lower an electrode and they can do a little electrical signal, and the patient can explain what they're feeling when they do that little zap, and that helps to sort of localize where you are within the brain. I think it's less common now that we have better stereotaxic equipment and better imaging to help guide us, but it's still, can occur, and certainly a lot of the pioneering brain surgery was done in that fashion, with the patient awake and a little, basically just kind of local anesthetic to sort of, I won't go through drilling holes in skulls and stuff. So anyway, the nerve cells within the brain don't themselves feel pain. It's going to be in the meninges, the blood vessels, and the cranial nerves. In some cases, so with classical headaches, which is obviously what I'm going to be talking about, they have particular sort of stereotypical presentations, which doesn't mean that you can't have something that doesn't fit the bill. But so we have sinus headaches, for example, where typically the pain is going to be sort of kind of somewhere, like tilted towards the face. So it's kind of behind the sort of brow or behind the cheekbones, that kind of thing. Cluster headache is very classically localized to one side only. And it's this really intense pain that is based kind of, the nearest you could localize it would be sort of right to the back of your eyeball almost. And it, as we'll talk about, has a few other characteristic features as well. Tension headache seems generally sort of much more sort of slightly high and sort of like all around, kind of a band around your, sort of squeezing your head. And then migraine has its big mixture of different symptoms, which, like not all patients will have all of the different symptoms associated with migraine, but they'll typically have, like a number of them. And classical migraines tend to be unilateral, so they'll affect sort of, typically they're on one side, but there are obviously, that's, just another of those features that can vary between particular patients. Typically, as we'll discuss, it has, like some kind of aura associated with it. So this picture always grosses me out, more so than drilling holes in people's heads. And so this sort of sinus headache is obviously down to some kind of sinus inflammation. And so typically it's going to be an infection of the nasal passages, leading to inflammation and congestion, causing pain and pressure in the forehead and behind the cheekbones. And so because it's really an infection rather than neurological, the treatments are all going to be sort of infectious disease type treatments. So it's going to be antibiotics, decongestants, and then corticosteroids if you need to sort of pull down the inflammation. Tension headaches are largely driven through the muscles that are present in the head. And so they're sort of, again, not really neurogenic except in the question of, like why the muscles are sort of acting up, which is obviously a question often related to stress. And for that reason, sort of, if someone suffers from a lot of stress, a lot of tension headaches, then, like sometimes, like counseling and stress management techniques and so on can actually help reduce their intensity and frequency. And often there will be sort of identifiable triggers for these things. And in terms of types of treatment, you're going to be looking at classical pain relievers, but then also muscle relaxants and antidepressants to try and relieve the underlying trigger for that sort of excess muscle contraction. Yes. Caffeine is yes, not so much for tension headaches, but caffeine is often one of the ingredients in some migraine medications. So I don't think it's well understood how it exerts positive effects, but there is some evidence for some patients that it really does help. And of course, some people who are fully addicted to caffeine, like myself, can have I haven't had a cup of coffee headache, and that helps with that too. So in terms of symptoms, if we're especially looking at tension headaches versus migraines, there's a kind of some levels of overlap of some of these symptoms. Like typically you don't, for example, have a mild migraine. However, you can have pretty severe tension headaches. And you can sort of, like at the sort of mid-levels, there's sort of like is some overlap in sort of reported pain score between, sort of some of the worst tension headaches and some of the sort of, like in quotes, milder migraine headaches. Tension headaches can be unilateral or bilateral. They're more likely to be bilateral. Migraines are more likely to be unilateral. Tension headaches rarely cause photophobia, i.e. like light making it worse, whereas migraines typically will have some photophobia. Tension headaches are less likely to cause nausea than migraines are, and are more likely to feel like a pressure headache and less like a throbbing headache. But there's, so the point of this diagram is to sort of indicate that all of these, everything in red could be a symptom of either of these things. However, yes?
Oh, so I was going to ask, can I get a slightly more advanced description of what an aura is? Because I'm not really clear on that.
Oh, it's coming.
Oh, okay. Thus far, a migraine seems to share a lot of symptoms of a really bad hangover.
Actually, that is, there is some, so hangovers are very poorly researched, probably because trying to find, yes, but I think the idea of getting someone to fund research on something that's self-inflicted is probably difficult. But actually there is a lot of similarities between the well, there are some potential similarities between the mechanism of the hangover headache, which actually probably are the same as the mechanisms that underlie a migraine headache. So possibly migraine medication would help, but again, good luck trying to get a prescription. So the more migraine-specific type features are going to be, like aura, vomiting, and aggravation by any kind of activity. This is why with sort of migraines, you tend to sort of migrate to sort of dark, still rooms, whereas tension headaches, you are more likely to sort of truck through your day feeling miserable. So we're about to sort of talk more about migraines in like a bit more detail. So does anyone, so instead of, we'll start the timer, but this time I'm going to ask you questions. So what do we know about where we feel pain in the head? Yes, it's not the nervous tissue itself. It's in some of these other features. What's the main, what would you do if someone had a tension headache? Yes, exactly. And sort of like, so basic sort of pain medication, and then if it sort of doesn't respond to that, so like over-the-counter sort of pain medications are going to be your first step, followed by, yeah, like if it's sort of like severe ones, psychological treatments where we're trying to sort of help them relax, followed by, if necessary, yeah, like the muscle relaxants and antidepressants and so on. If it's sort of, yes, or at least you won't care, whatever. So, and what's the difference between a primary and a secondary headache? Yes, exactly. And so that would obviously have a big impact in how you would be wanting, what level of care someone would need. Like if someone comes with an axe sticking out of their head, it's probably a secondary headache. Yes, in primary, the headache is the underlying disorder. So you would be regarding the headache itself as what you're trying to treat. So like if, for example, like, one of the most severe headaches you can get is meningitis. That's pretty severe. And, but you wouldn't give them sort of like ibuprofen and, to say, go sit in a dark room until you feel better. You would be sort of giving them antibiotics to sort of, because that would be the primary cause that you can deal with. If someone has severe migraines, they might feel just as bad, but antibiotics obviously won't do any good. And you would be focusing on the migraine treatments, which we're about to sort of kind of touch on. And obviously, this class is sort of like kind of a combination of pathophys, pharmacology, and therapeutics, kind of, but it's so it's kind of an introduction to headache, I guess. So migraines are these sort of like funky headaches that are, like have their, like typically very sort of moderately to very severe, and have major quality of life issues for the people who have them. So one of their features that is, if you have aura, then it is pretty much definitive for migraines. However, not all migraine sufferers will experience aura. And aura is basically some kind of sensation that occurs sort of as essentially almost like a warning that you're about to have a migraine. And they can be a bunch of different symptoms. Some of the more common are visual aura, which can be positive, which means that it's something added to your, like kind of experience. So positive visual aura is typically things like scintillations, which are these rapidly oscillating visual distortions, or photopsia, which is flashes of light, or tychopsia is a single, like a spot of flickering light. So these are obviously, you're not being visited by aliens. This is, like something that your mind is generating. You can also have negative visual symptoms where, for example, you might lose a portion of your visual field, either sort of dimming or actually just flat out losing a chunk of your visual field. So, and these are sort of temporary. It's not like these patients are walking around with these things all the time. This is essentially their personal warning sign that they're about to get a migraine. There can be sort of an aura, which is kind of a motor aura, where, for example, you might have impairments or clumsiness in speaking. So that's dysarthria. It can be vertigo. It can be tinnitus. It can be impaired hearing. Whoops, excuse me. So hypoacusia. It can be double vision, diplopia. Lack of overall ability to sort of, like gross coordination. So ataxia, or a decreased level of consciousness. Or it can be sort of even in the sort of touch field of sensation. So you can get paresthesias, which are sort of abnormal or kind of unpleasant sensation. So numbness or prickly feeling or sort of mild burning or something like that in regions of your skin. On, you know, like both sides of the face, arms or legs and so on. So all of these things are, you know, like symptoms that emerge prior to the sort of pain phase of the migraine. And, you know, like the presence of aura is, you know, like one of the definitive clinical features of migraine. During the headache, typically the patient will experience, you know, like intense pain, typically nausea, and then photophobia and phonophobia. So, you know, like dark, silent room. So the question comes is sort of like what's actually happening in these patients. And as you'd imagine, it's not the easiest thing in the world to study because obviously they occur erratically. Many patients do actually have a trigger which they can eventually identify. But one of the things that has emerged is that it does seem to be involving the vasculature within the head, and especially the trigeminal nerve. So we have one of the sort of kind of simplified views of what happens in migraine is that it's an inflammatory condition affecting the fifth cranial nerve, the arteries, and the reason that the pain gets so severe is that you get some amplification of that pain that's occurring at the level of the thalamus. And the thalamus is obviously then, so amplifying that as a signal to, you know, like your somatosensory cortex and so on. So the sort of stages of migraine sort of initiation, if you like, and this sort of typically is a process that seems to take several hours, which is why, you know, sort of migraine headaches are typically last for hours, is for some reason, and this is the bit that's sort of like very fuzzy and related to whatever an individual patient's triggers are, the fifth cranial nerve, the trigeminal nerve, gets sort of overstimulated somehow. And so you start to sort of develop some kind of pain through the face and so on. And after like a while, the trigeminal ganglion starts to release some peptide neurotransmitters. And so it includes neurokinin A and substance P, but probably the most important is going to be the calcitonin gene-related peptide. And so we have these processes, the release of these peptides is throughout the system, resulting in sensitization. And in particular, it's leading to vasodilation of the arteries within the head. And because these arteries are becoming strongly vasodilated, they are starting to experience pain. Yes? Yes, actually, that's true. Yes. Yes, yes, absolutely. So you get the vasodilation, and that's sort of generating the sort of experience of pain. And then that's where actually the hangover pain is thought to be related to sort of vasodilation and obviously to some extent inflammation driven by dehydration and some of the congeners in most alcohols and so on. So that's sort of, you know, like why the hangover headache is this sort of throbbing headache. One of the differences in the migraine is it's then getting amplified through the thalamus after a few hours. And that we then start having this sort of kind of feedback loop where we're getting this sort of strengthening stimulation of vasodilation in the arteries combined with heightened experience of pain from that area, which is giving rise to this sort of really severe headache. One of the interesting questions about migraine is, because this is kind of a wind-up situation, is like, why does it stop on its own? Because, you know, like, as far as I know, no one's ever had like a sort of like a migraine that's lasted longer than sort of, you know, like 8-12 hours, something like that. So there has to be some self-limitation process that kicks in. I don't believe it's well understood. So for patients with migraines, what can you do about them? So there's some acute treatments. So typically sort of NSAIDs with caffeine, acetaminophen. Some of the earlier drugs that were migraine specific, because obviously NSAIDs aren't very migraine specific, are the ergot drugs. So these are derived from a fungus. And these are drugs which they're sort of, I think they're more used as sort of like third line treatments these days, but they have, they mediate their effects, causing vasoconstriction through serotonin receptors. And you don't need to remember which serotonin receptors at this point, until we start pharmacology. The ergot drugs have been replaced by the triptan drugs, which are more specific for the specific serotonin receptors, and also have significantly less toxicity. In rare cases, I think nowadays, patients will also get opioids to help with the sort of pain relief. And because migraine is so associated with nausea, and because patients with migraine have their pain exacerbated by movement, you know, like, so throwing up is not the best thing for someone, and they often will get anti-nausea medications as well. So all of those are sort of treatments that you can give to someone who is having a migraine. What about preventing them? Because if someone is repeatedly having migraines, then that can be an issue too. There's a bunch of different approaches. There's beta blockers. So they make it harder for your arteries to dilate. And so they kind of like can short circuit that process of you know, creating the migraine in the first place. And in a similar way, there are drugs that like calcium channel blockers, which are doing essentially the same thing. So these are basically blood pressure medications, but they're being used to treat migraine. There are some types of antidepressants that can also be used, and anticonvulsants. That's valproic acid and topiramate. Interestingly, in more recent years, there's been some success where patients have had Botox injections, not in their face, but to the trigeminal nerve, and that reduces the ability of that nerve to sort of essentially experience, well, it acts on synaptic transmission in that nerve bundle, and so by suppressing the activity in that nerve, it prevents obviously this ability of excess excitation and so on. And then just recently, this year in fact, there's been a new class of prophylactic migraine medications, which are calcitonin gene-related peptide inhibitors, which is why I highlighted them. So these are, the first one came out in May of this year, and I think there's been 2 or 3 since then. So these are a completely new class that has literally just come out onto the market. And what these are antibody-based inhibitors of the CGRP. And so they're antibody-based, as you probably I don't know if you've done this in pharmaceutics yet, but because of that, they sort of require injections and so on. And so again, this would only be a treatment for people with very severe repeated migraines, because obviously most people don't like having lots and lots of injections. So we will talk about cluster headaches at the beginning of Monday's class, and this is just a short section, so we're almost completely up to speed now. And so I will